I know. It's real frustrating because
Hands especially are
you
kind
get
of
the
the
cracking and the
biggest.
burning and
Yes.
and like for me, it was like, especially Did you already got the white, right? Okay. Hi, I want to welcome you. We are excited today to have a media briefing talking about a new research grant that has been received here at the University of Oklahoma Health Sciences Center. It's a $1.9 million grant to study what is a workplace hazard, but it could also be a hazard in your home or in other places you visit. So we're going to talk a little bit about the condition. The research actually focuses on a condition that is called irritant contact dermatitis. Big, long name, but we're going to talk a little bit about what that is. It's more common than you think. Most of us have experienced it. And from the dermatology side, I have with us Dr. Pamela Allen, and she's on my left, your right. She's going to talk about the condition, what it is, how it occurs, how it's typically treated, and also differentiate it from another condition that some people might think it is, but it's not. So we'll talk a little bit about that. And then on my right, your left, is Dr. Randy Gallucci, and he is with the University of Oklahoma College of Pharmacy. And Dr. Gallucci is the researcher who is heading up this project and received the grant. We're very excited to have it. And he's going to talk a little bit about what his research will do, what his laboratory is focused on, and what ultimately they hope that this research will lead to in relation to this condition. So with that, I'm going to turn things over to Dr. Allen.
Thank you. Well, irritant contact dermatitis is a type of eczema, which is an inflamed type of reaction of the skin that can cause blisters, crusting, cracks in the skin, very dry skin, but it is caused by some sort of irritant chemical or product that your skin is exposed to, and it can happen actually even on the very first exposure, and repeated exposure to that irritant can continue to make the skin very, very inflamed. And we know that 80% of irritant contact dermatitis is caused by occupational type of work. And so that is something that is extremely important for us to remember and explore. How does it differ from allergic contact dermatitis? Many people think about, oh, I have an allergy to everything. That's why I'm irritated to these things. But an allergic contact dermatitis, when you're first exposed, your immune system builds up that sensitivity, and it's not as robust of an inflammation as consequent or subsequent type of exposures. It takes 10 to 14 days in an allergic contact dermatitis to build up the immune system against that allergen. But on subsequent exposure, within 24 to 48 hours, your skin will erupt into blisters, itching, pain, burning. And when we talk about allergic contact dermatitis, the most common things that come to mind include poison ivy, poison oak. Sometimes it's acrylics that women use on their fingernails, things of that nature, and certain ingredients within products. But our daily irritant contact dermatitis issues include a lot of occupational hazards, and so we'll talk about that a little bit more.
Just before we get off of that, and before we get into the research and how this works, I was surprised that it's things like soap, it's the kinds of things that trigger these reactions. Can you talk a little bit about common substances besides, you mentioned the nail lacquer? You even mentioned like a massage therapist who was actually the oils that were impacting. So it's something, and it's usually the hands?
Well, they can be solvents, they can be detergents with regards to irritant contact dermatitis, even water. Within a wet work type of occupation, such as within the medical field or within restaurant business where you're washing your hands 20 to 40 times a day, you will continue to strip the natural oils out of your own skin, especially if the water is is on the hot side. And so that becomes in and of itself an irritant. But it can be the alcohols within antibacterial soaps that are commonly used. It can be many times some of the stripping soaps that mechanics have to use to get the oils off of their hands. And many times it's preservatives and things as well. So it's a variety. There's hundreds of different irritant type of agents that can people can be susceptible to.
And how do you treat it?
Well, first of all, you must try to identify the agent and avoid it. For irritant contact dermatitis, if you avoid it, it actually may dissipate and clear up within a few days. But if you are not able to identify it and you are continually exposed to it and you're not able to avoid it, maybe because of your work, your skin will become very red, irritated, and become thickened at times. You'll want to utilize products that are without an alcohol-based ingredient. Yes, there are many things over the counter that say hypoallergenic and fragrance-free, but they're not truly completely all regulated by the FDA, so you're really not sure if this product or that product is good for you. But there are certain products that are completely free of dyes, fragrances, masking products, lanolin, and you have to look hard, but there are those that many times we will recommend. Sometimes topical steroids, corticosteroids are needed to calm the inflammatory part down, and if it's extremely bad, many times our oral cortisones may be needed, in addition to itching type of medications such as antihistamines.
Dr. Gallucci, we're going to turn it over to you now because this is a very large grant, and I think a lot of us think this is just a minor issue with hands, but this is actually quite an expansive issue in the workplace. Can you talk about, first of all, the grant,
Sure.
what it will allow you to do in your laboratory, and then talk a little bit about the science, what you'll be looking at.
Okay, well, first off, to address what you were saying about the importance of this, as far as occupational injuries go that cause workplace or loss of productivity and that sort of thing, skin conditions are number 2 of all of these workplace injuries. And as it turns out, 90% of those are associated with dermatitis. 80% of that, the dermatitis, is caused by irritant contact dermatitis. So it's actually a very, very big problem in the healthcare industry, especially. Even though it's a relatively small segment of the occupational population, there's a large percentage of patients within that population that wind up having occupational dermatitis, where it's like 61% of healthcare workers at some time seem to have some symptoms of contact dermatitis. There was a bunch of studies done with physicians and surgeons, like ICU nurses. They did a snapshot study in 2007, looked at ICU nurses. 65% of them that were working at the time had demonstrable contact dermatitis. 50% of the intensive care nurses had demonstrable dermatitis. So it's a very big issue, yet very little research has been done on it. As Dr. Allen was saying, a lot of people, when they think about dermatitis, they think about allergic contact dermatitis, which is, the poison ivy type of thing. And a lot of research has been done on that as well. But that doesn't take into account of the prevalence of it, right? It's, there is a certain population of people that seem to be susceptible to contact or this allergic contact dermatitis, but almost everyone, it seems, at some time winds up having some sort of irritant contact dermatitis, because there may not necessarily be an association with a predisposition of the immune response to pick up something in order for it to occur. It just happens to be that a person is exposed to a lot of water, is exposed to this chemical or something like that can cause this to happen. So in that respect, it's a big problem that is yet to be addressed, okay? So the way that our lab is going to look at this is the focus of our research is on inflammatory responses, Okay, so we try to dissect how inflammation occurs, and obviously inflammation of the skin is dermatitis, right? So we have these animal models where we take a look at different irritants and how the inflammatory response varies between these irritants. So we're going to look at things like detergents, okay? Just normal ones called SLS, sodium lauryl sulfate. If you look in a bottle of shampoo, it's there. It's in hand soap. It's in all kinds of things. Benzalkonium chloride, which is another good one to look at, very irritating, and it's in sanitizing wipes. You see it all the time. You go to Sam's Club, Walmart, you pull up one of those wipes to wipe off your cart, that has benzalkonium chloride, and that causes pretty severe irritant dermatitis. So that's one of our models as well. We also look at petroleum products too, because they tend to cause a different type of irritant dermatitis that looks a little bit different, but is actually quite severe. Some of our earlier work was done with JP jet fuel, where we looked at, and this causes a very severe dermatitis, especially in flight line workers in the military. So, and it's an irritant contact dermatitis. It's not, there's no allergy associated with it. So, but it looks just horrible. It's caused thickening, crackening, fissures in the skin. It's weepy and that kind of thing. The weird thing about it is it's not painful or itchy. You know, they'll go into the physician and say, oh, I've got this horrible dermatitis. And the physician will go, oh, well, geez, that looks like it hurts. And they go, oh, no, it doesn't hurt at all. It just looks horrible, you know. But like any other irritant dermatitis, if they can get away from it, then they won't have the problem with it. So, but the problem is getting away from it, right? Because it's their job. They have to work on the flight line. So anyway, what we're going to do is we're going to look at these different irritants in these mouse models and see how the inflammatory response differs between each of the irritants to see if there's something in common between them or if there's something different about them that makes like JP8 jet fuel worse than sodium lauryl sulfate, okay? Then we've also got a mouse model that is deficient in one of the inflammatory genes. It doesn't make one of these inflammatory mediators, okay? It's called interleukin-6. And we had previously shown that these mice don't heal very well. But since it's a pro-inflammatory mediator, means it causes inflammation in the skin, we thought, oh, well, if we put these inflammatory or these irritants on the skin, the mice will have less of an irritant response. Actually, it turned out completely the opposite. These have much worse of an irritant response. So we're going to try to characterize what exactly this inflammatory molecule does that protects these animals from, or protects actually the wild type animals, normal animals, from this contact irritant dermatitis. The second part of our grant will look at, once we've characterized what these irritants are doing and what genes are associated with it, we're going to try to put these genes back into the animal to see if there is a protective response with a specific gene that's not IL-6. You might ask, okay, well, if IL-6 is protective, why don't we just give it to humans as a treatment or something like that? Well, a normal human can make a lot of it and does it normally. And people have been trying to turn this into a pharmaceutical and it doesn't really work. So what we want to look at is downstream from it to see what it's doing to protect the animals, right? What other genes are being turned on? Does it have something to do with skin barrier? Have something to do with knocking down the inflammatory response or something like that. So we're going to try to add these genes back into the skin of the IL-6 deficient animals, see if it'll augment the protection in the normal animals that are associated with, or that are given the irritants as well, and see if that can somehow be turned into a treatment by modulating how this gene is being expressed, or by giving the gene product like a protein or something in a cream or something like that to see if that helps the skin integrity. Now, the third part of it actually has to do with, we're collaborating with some scientists at the Centers for Disease Control, National Institute of Occupational Safety and Health. Our co-investigator, Dr. Yukasoy, there has a patient cohort of about 840 patients where they patch tested, which means that they take a little patch and they stick it on the back of your scapula, and they have an irritant on there. And they leave it on there for about 5 days, and then they pull it up, and then a pathologist reads it and scores it and says, okay, this person had a bad reaction, this person didn't have a bad reaction, or whatever. And they looked at sodium lauryl sulfate, okay? And so what they did is they took these patients and they scored them to see who was a hyper responder and who was a normal responder and not a good responder or whatever. And then they took blood samples from the patients, and what we're going to do is look in those blood samples for genes that might have a mutation in them that are associated with the activity or function of this interleukin-6 gene, this inflammatory marker, okay, that we found in the mouse that seems to be protective. And we're looking all around the gene, not just at the gene itself. We're looking at it, everything having to do with its receptor and other inflammatory markers that are associated with it, and any other skin integrity genes that may be modulated by the inflammatory marker and that sort of thing. So those are our three aims. So the third aim would be along the lines of protection as far as workers go. So what one might envision is, say, a genetic analysis, where you could take a cheek swipe, and of course this would be between you and your physician, and determine whether or not you had any sort of susceptibility to, say, irritant contact dermatitis. And then you'd say, okay, well, you do, so perhaps you can take these precautions. You can use this particular type of protective equipment, or this type of barrier cream or something like that, that might help you with your job.
Because without, I mean, there's no real, I mean, the only cure is to avoid, correct? Dr. Allen, is that correct?
That is the primary goal, is to avoid it in the first place.
Yeah, at the moment.
That's
Yeah.
right.
Right now, that's what we have.
Yeah.
So if your job entails utilizing a substance, you mentioned healthcare, and I think about healthcare. Healthcare is one of those things where they wash their hands, they use, antibacterial, antiseptic, often.
Mhm.
The other setting I think of is a daycare setting,
Yep.
and then as well as the industrial settings, where that tends to be what we think of as the more caustic chemicals, but this can
Right.
be really common, simple things that we might even have in our homes,
Yeah.
correct?
That's correct.
Absolutely, yeah. You can, well, like you said, in an industrial setting too, there's a lot of cutting fluids and that sort of thing that machinists are exposed to that cause a very severe dermatitis, very similar to that we see with the JPA jet fuel. And about the only way to I mean, if you're a machinist, that's what you have to do. There's no way around it. And they just, these sorts of occupational exposures and injury tend to be well underreported, because they'll just say, oh, well, that's part of my job, But still, in 1985, they did a cost analysis, and it showed that it cost the healthcare industry to treat these dermatitis somewhere between $200 million and $1 billion. Now, that's 1985. So you can imagine what it might be today, because there really is still no treatment. The idea back then was to avoid it, and now it's still just to avoid it. Well, it's part of your job. What are you going to do? You're a machinist,
Can't quit your job.
Exactly, yeah.
From a perspective of, and I guess I have to understand the healing process, and Dr. Allen, can you talk about this? Once you have this, and Dr. Galucci, I don't mean to pick on you, but you even actually have some on your hand
I
right
do.
now, correct?
Yeah.
And that's from what, washing your hands?
Yeah, working in the laboratory, you wash your hands all the time, and then you have to wear gloves, and you strip the gloves off, and the gloves can have irritants on them, and wind up washing that off too. And one of the big things that they tell you to do is to put on barrier creams, but you're washing your hands and stripping the gloves off and that kind of thing too. So the barrier creams, there are some that are recommended for healthcare workers because they don't wash off very well, but then a lot of them, I don't like the feel of it. Tell you the truth, it's kind of greasy, and I'd rather deal with this than, have to put the barrier cream on all those.
So the healing process, when this happens, and I know you mentioned some of them don't hurt, but some of them can actually burn and crack and hurt as well. Is that correct?
Very much so. I mean, it can be so itchy that you feel pain more than itch. Our itch fibers and nerve fibers are very close together within the skin, and so many times people have so much itching that it turns into stinging, burning, pain type of sensations. And so I agree with the need for some sort of healing process to happen when you have formed cracks, fissures, and you really can't do that from the inside out. You must have, the skin is the largest organ of the body, and so it's our environment, it's everything that we come in contact with that can break down a lot of our barriers, which include lipid-containing type of molecules that can give us our natural oils of our skin. And so if we are continually stripping those off with hot water, frequent washing, these chemicals that Dr. Galucci has already talked about that can be quite harsh, your skin is going to break down. And so we within our Department of Dermatology, since we see this quite often, still recommend at this moment gentle cleansers without all of these ingredients that we've talked about, but also remember that your skin after washing is going to evaporate the water, and unless you seal in the moisture beads with some sort of a heavy oil-based product, remember that lotions are more water-based. They're going to evaporate. Yes, they're not as greasy, but they will not stay on your skin very long. And so you want to look for things that are thicker in their consistency, such as heavy creams, and for those who like the more oil or ointment-based type products, and there are those that are not as slick, but those are much better for you. They will hang around easier, but also start to seal in those cracks where they won't become potentially infected.
So there are currently some barrier creams. Are you hoping that your new treatment would be a topical? I mean, I know that's way down the road. Is this something we think that we could at some point maybe apply to the skin, or?
That's the idea. The idea, instead of having to put on a barrier cream that hangs around and it, annoys you, that kind of thing, is kind of greasy or whatever, that maybe there is some sort of pharmaceutical that you could put on maybe once a day, once a week, who knows, once a month, that would increase the barrier function within the skin itself. You build up your own barrier, because that's the big problem, right, is that, especially with washing your hands, water itself, I think Dr. Allen had mentioned, water itself is an irritant. And especially here in Oklahoma, where our tap water has a very high pH to it, and that a lot of those enzymes that are associated with barrier in your skin operate at more of a physiological pH. So you put this water on there that's a pH of about 8 or 9 on there, and all of a sudden these enzymes don't work very well. So the barrier of your skin is literally disrupted by you putting water on your hands. So, if you can use this pharmaceutical that will artificially build up the barrier on your skin, keep it nice and intact, then you wouldn't have to worry about using barrier creams or anything like that. You just wash your hands, it's normal.
You can keep your job.
Yeah, exactly, you keep your job.
A couple questions. So I'm interested in, my editor's always interested in the lab to the bench, or to the bench to the bedside,
Right.
You've got the grant for 4 years. Do you have any kind of anticipation of what you'll be able to do within those 4 years? Will you be to a testing phase as far as pharmaceuticals concerned?
At this point, it's still investigational.
Okay.
What the Centers for Disease Control and National Institute of Occupational Safety and Health are concerned about as far as this goes, by the end of this grant, they'll want to know about prevention and surveillance of workers. So the point of the grant really is to define what the problem is, how it varies between irritants, and whether or not we can predict this problem occurring in a particular human population, so that we can use the current therapies optimally, is the idea. Can we use barrier creams, or are there different barrier creams that we can use that are already available? In the future, yes. In subsequent grants, when we wind up looking at the mechanism and what these proteins are that may be associated with interleukin-6 function, if we can in turn find ways of modulating those genes and turning that into a pharmaceutical, yes, that would be the ultimate outcome of that, would be to wind up with this treatment. But that can take some time. You're talking about, even if we had something that would work in animals, then we've got to go to different models, and it's got to go to clinical trials in humans, and then you've got a decade getting through FDA submission and approval and that sort of thing. So, but yeah, ultimately that's what we would like to do, is come up with something better than a barrier cream,
I'm interested if CDC and NIOSH have any kind of recommendations of how to identify that. I mean, industrial settings, solvents, it seems obvious that you've got, OSHA safety meetings you've got to attend, but people wouldn't think that water and soap would be something that could be a potential workplace hazard. So how does the employer or employee identify that? Is that part of what you're looking at?
Well, when they have an occupational safety or health program within an industry, they have industrial hygienists that are supposed to educate the workers on this, that actually would go within the purview of the company itself, right? To make sure that they have this surveillance and identification and education component within the company. That's about as good as you can do, you know. So they would have to say, provide, okay, well, you can use these barrier creams. Make sure you use this type of glove when handling this type of solvent or something like that. But at the moment, everybody's treated the same. There is no way of saying, okay, this person, right, you need to use this type of glove, right? You shouldn't be near this solvent unless you're using this type of glove. So there's no differentiation between one worker to the next, right? So, and of course, there's all kinds of ethical and legal issues that come with this sort of thing. So we'll leave that, you know, for them to work out that later, perhaps, like I said, is between you and your physician. And you would say, okay, well, I have to use this type of cream, and then you don't explain why or whatever. But, you know, there's privacy issues.
But so
associated with that.
ultimately, not everyone reacts the same, even when exposed to the same
Yep.
chemical or situation.
Yep.
That is true.
That's true. You see a big variance in,
Yes, and I would say this, in identifying what ingredient or chemical that a person is potentially irritated to, it takes an extremely detailed history. You must have an extremely, very thorough history taking. So that usually is going to come more so from your dermatologist, and really getting into, what are you doing on it? What is your work? What do you do for a living? What are you exposed to? What type of, products are you using on a regular basis? And really get down to exactly what are the products, and if, when they are away from work on the weekends, things tend to clear up, but then when they come back to work, they're exposed to the very same things, and trying to narrow down. And sometimes it's hard to narrow it down to the specific item. So many times we do what's called patch testing, which is a type of test which has numerous allergens in little square wells that are applied and taped to a person's back. And so within our office, we have the True Test, and it has about 32 different allergens. There are people who specialize in contact allergy, even within our city here, and they have the extended tray where it has at least 75 or more allergens that can be applied to the back, and then within 48 hours they are removed, and you will see if there are actual inflammatory responses to certain wells that are identified by certain chemicals. And so that's one way to narrow down and to identify what it is, and then go looking into their occupational or their environment for those products that contain those types of things.
and I know this is probably overly simplistic, but I get a little confused, and I think the public probably gets confused because in the smaller percentage of cases, there's actually an allergic reaction. That's like like when we have allergies in the nose, there's a histamic thing that's happening in the body, right? Histamines. But in the irritant, it's actually an inflammatory response, or is there a little both?
Well, histamine is an inflammatory
Okay,
Yeah,
mediator.
that's
they're
right.
both inflammatory responses happening, but it's based on which part of the immune system is getting triggered, and what the time frame of when it happens. First exposure versus the second, and usually the second exposure is much more intense. You're talking about, possibly, your bee stings. Those are that's an allergic type of reaction. You may not have as much on a first response, but on that second response, you're going to get swollen of the eyes. That's it's definitely more severe. This irritant type of contact dermatitis is a chronic type of thing that just continues to build if you are exposed to it. It's not a quick, extreme, immediate thing, but can be for some people, and it's of different severities along the spectrum for many people.
And it depends on what arm of the immune system that is being activated by the irritant. It's because we talk a lot about sensitizing chemicals and non-sensitizing chemicals. So when it is a sensitizing chemical, that means you get the bee sting response, right? But in the skin, it's manifested differently in just that severe sort of, poison ivy type dermatitis. If it's a non-sensitizing chemical, which is what we're primarily working with, you only get so far in the immune response, okay? You get up to the point where it looks, or where it activates these cells called neutrophils or macrophages, but it doesn't get any farther than that. These other cells that are involved in the bee sting thing, or poison ivy called T cells, they never see anything, right? So there isn't an antigen for them to see, to recognize, so they just ignore it. So it, like we said, it does get severe and it is chronic because you're exposed to it all the time, but you don't have any what's called immunological memory to it. So every time you're exposed to it, you may have a response to it, but it doesn't really get any worse. Whereas allergic contact dermatitis, you'll have a mild, like irritant dermatitis to it. Then the second time you're exposed to it, oh my gosh, it's just huge. You get an enormous response to it.
That makes sense. Does it physically look any different, or does it typically look the same?
It can look the same. It can look the same. I would say that the allergic contact, though, is going to be more robust as you are subsequently exposed on certain occasions, and it's blistery.
Yeah.
It's swollen. It's not a dry, cracked type of thing. It's an acute response. As instead of, an irritant, you're going to have cracks and fissures, you're going to have swelling. You may have blisters, but it is not this, intense swelling only until you have, been exposed for such a long time that your hands look like hamburger meat, pretty much.
I covered the ones that were on here, so unless you have any others from workout? Fascinating.
Cool.
I might have Jim get a shot of your hands, but the funny thing is, when I was reading over this, the water issue, I was baking for my mom for Christmas